No, jolly good. In which case, I'm going to go straight into the patient's story, which is going to be delivered by Fiona and James with support from the lead nurse in paediatrics, Simi. So over to you, Fiona, I think.
Morning, thank you, Chair. So I'd like to hand over, as you've described, to James Gillespie Allen, who's our Head of Patient Experience, and Simi Naidu, who's our Head of Nursing for Children and Young Persons. And they're going to be talking about the implementation of the Parent Journal. Thank you, James and Simi.
Thank you. Good morning. For those that don't know, my name is James, Head of Patient Experience, as Fiona has mentioned. Here today to share with you the Parent Journal that's been launched within Paediatric Services. Essentially, the Parent Journal is a diary for parents or the guardian that's looking after a child to note down key information relating to their child's care. It's been co-produced with the family of Georgie Stanton-Watts and ward staff from Paediatric Services. And it's also had input from Northamptonshire carers, Health Watch, and families who have used the ward. Georgie was cared for on Skylight Ward at KGH from the 1st to the 6th of October 2016, and she was transferred to Leicester Royal Infirmary, where she sadly died on the 8th of October, aged 23 months. Georgie had a condition called panhypopituitarism, which is a lack of secretion from the pituitary gland, and this can in turn cause other health problems. She was under the joint care of KGH paediatricians and LRI paediatric endocrinologist, and her complex medical condition meant that she's seen more than 60 admissions in her short life to KGH and PAU. Georgie's death was referred to the coroner's court and an inquest was subsequently held, and this identified 5 areas for improvement. Over the past 2 years, I've been working with the family, liaising with the ward staff with regards to the family's proposal of creating this journal. And I'm pleased to share with you all that on the 17th of December, KGH with the family formally launched this within Paediatric Services. And as part of that launch and as part of raising awareness with staff, we created a training video, which I'm pleased to share with you today. So I'll hand over to IT.
Nicola and Stephen's daughter Georgie was born with a complicated condition, which meant that she spent numerous times in the admission ward at Kettering General, and also she had numerous stays on Skylight Ward. From the contacts with the assessment unit and Skylight Ward, we quickly learned that although Georgie had her own named consultant, while she was on the ward or the assessment unit, she would be seen by various consultants and numerous registrars and nursing staff. When a child is in hospital, parents tend to have to juggle the hospital stay along with the normal day-to-day pressures of family life. Something as simple as arranging the care for the other children can lead to very stressful situations for the whole family. It may look as though all they have to do is to sit by the child's bedside, but the reality is completely different. When Georgie died, we wanted something positive and helpful to come for support for families in the same position. We thought about what could have helped us. We came up with the idea of the journal where we could record all the information, advice and changes in one place. Also, we would be able to write down our understanding in our words that we could clarify with staff if we needed to. The journal would belong to the parents or carers and would stay with them. It wouldn't be written in by any professionals. It becomes the patient's record for the parents. Passing information on to other carers becomes easier. It's written down when it's discussed. It will also help with the continuity of care throughout hospital stays. For the families of children being admitted for the first time, it will enable them to understand the reasons for care and treatments, and somewhere they can record relevant information that may be useful at future dates. For families of children who attend hospital regularly, it is their record of treatments of medication that have worked in the past, and also, more importantly, what has not worked in the past and why it didn't, including any side effects.
Hello, my name's Jodie. I'm a staff nurse on Skylark Ward. The journal is a simple place where our parents can write key information regarding the care of their children on the ward. This will help improve communication with our children and families.
Hello, my name's Jane Lafferty. I'm a senior sister here on the local neonatal unit here at Kettering General Hospital. Obviously, we can appreciate that having a child in hospital is a very challenging and stressful time. So therefore, having a parents' journal will help them take, some responsibility and keep a track record of what care their child's been given. This is their journal, their record, so let's help them put that into practice.
Thank you. I'll hand it over to Simi to update you.
Thank you very much, James. So really, this was an opportunity for us to work with a family that had some great ideas about how we could improve care for children and young people coming into our children's ward. So real powerful story about how co-production works when it works really well. And so working with the family, we were able to get to a finalized version of this journal. We know that when a child and their families come into hospital for an admission, this is an extremely stressful experience for not just the child, but for the family, the parents, the siblings. And in those first few days of life, lots of information is given, but also this family and this child need lots of people, different professionals. And during stressful situations, we know that we retain information less robustly, and we forget people that we meet. So the parent journal really is an opportunity to signpost families, to record information in a meaningful way, to capture individuals that they've spoken to and decisions that were made. But it really empowers our families to be involved in how care planning takes place, and to contribute to decisions around care plans, management pathways, referral plans for their child. So it's not only giving patients and families a voice, but it's actually empowering them to be part of that decision-making process. One of the most successful things that we've achieved through this journal is that we've been able to use this opportunity to really build on valuable principles that will help us create a service that is focused on the patient, but involves the family. So what has this journal given us? So many good things. It's helped us to recognize that patients and their families are our assets, that we absolutely have to capitalize on the opportunity to work with them and listen to what they have to say about their care. It really builds on using parents as advisors and contributors to the service, because they know their child a lot better than we do. And so really listening to what they have to say, what's changed for them, and how those conversations contribute to ward round plans, and actually just care planning through the day. It's helped us build a reciprocal relationship with patients and their families, because the journal isn't seen as a barrier, it's seen as an empowerment tool. And from feedback, we know that staff see it as a really good contributor to how families keep trails of conversations that they are having with clinicians and nurses. We've built relationships with our different partners, so some of our community sector, but as well as other patients and staff who have consulted as part of the co-production of this journal. And it also creates really clear boundaries around who's making the decisions and how we're working together to ensure that that child gets the best possible care in that time. So this is a really exciting opportunity for us to pilot such a powerful project. The journal, like James has mentioned, the journal's been in place since the 17th of December. We offer it to every family coming into our service. The uptake is more with patients with complex needs rather than short stay patients. We have about 150 children with complex needs that come to our service through the year. So we are in the process of writing to them and sending them a copy of the journal in the post, because we want every patient and their family to have an opportunity to access this really successful piece of work, but also a meaningful piece for them. We have had conversations with our system providers in Northamptonshire, so the Children's Integrated Board, to look at whether this is something that would be of interest to them, so that we have the journal promoted more widely across Northamptonshire. And I have forwarded a copy of the journal to the Deputy Director of Children and Young People for NHS England to look at their views and feedback on the journal and whether this could be a national project. The thing to say is that this journal is the entire responsibility of the child and their family. As a health provider, there is no legal requirement from us. They contribute to it. It would be the same as them recording a file note on their phone or a notebook. All the journal provides is a really guided way to document towards their child's care. And so we are hoping that this journal is the new standard for children and young people going forward, not just in terms of how they have a contribution to their own care, but actually how we use the journal to shape children's services so that it puts children at the centre of their care, and we work in partnership with families. Thank you very much.
Okay, are you guys
Thank you
finished?
both. Yes, thank you, Chair.
Okay, any comments or questions relating to that at all? Janet first and then Richard, I think.
Thank you. I'd just like to say and compliment all of the team and everybody involved in pulling this together. It's clearly a really great way for patients and relatives to have a voice. I wondered, and probably this is to Fiona, whether some of the principles and concepts within this would be something that could be incorporated into other areas of patient care. Thank you.
Thank you, Janet, and a very sensible question in regards to some of our elderly care areas in particular we've been thinking about, but also as the audience will probably be aware, for those patients that have learning disabilities or autism, we have their own sort of health passport, which we use within the organisation and share across the two organisations as a group. But the idea of the patient journal has also been shared with other senior nurses to look to see if we can utilise this concept in other specialty areas.
Okay, thanks, guys. Gomati, I see you've joined the call. Do you have anything you want to add as a paediatrician? No? No, you're not coming up. Okay, we'll collect some comments. Richard, Debbie, then Lisa, please.
Thank you, Chair. So, Simi, thank you very much for your presentation today. Clearly a huge amount of work over a long period of time. So thanks to you, the team, and thank you to Stephen, Nicola and Zena for helping us develop this. So my question is, as a parent, you're also given a red book. I remember the red book of my two sons. So how do we help parents who are coming into hospital with their child over and over again in this situation understand the difference? Because there's a lot to take in at any rate, let alone, and I know this will help, but how do you understand the difference between a red book and a yellow book? Thank you.
Okay, Debbie?
Yeah, thanks, Chair. So I just also wanted to add my thanks, especially to Georgie's family. I had the pleasure of meeting them a few weeks back. And it's been clearly a very difficult, challenging and sad time for them. So for something really as good as this to come out of it, I would just really like to say a huge thank you to them. The question that I had was just around feedback so far, Simi. So thanks for the presentation. You've clearly given some of these booklets out already, which is great news, but what feedback have you had so far? Thank you.
And Lisa?
Yes, really just to reiterate what Debs has just said, which is huge thanks to the family for this incredible bit of work. But then to back what Janet said, we've had patient stories previously where actually the patients have said, if only they'd listened to me. And I really think the NHS requires us to do personalised care planning, requires us digitally to actually give patients a forum where they can write into their record. So I really would ask us to really think about how we expand this paediatric parents journal to actually something that's much wider and available for people who are going through their journey and actually want to record what has been said to them in previous outpatients. Because even I, when you go into the hospital and see the consultant, forget what's just been said. So it's brilliant if there is somebody with you and you can write it down, you know. And I said even I, because I'm used to hospitals, I'm used to the system. And everybody gets overwhelmed when you actually walk in and get news from a consultant.
Okay, Gamathi. You're still muted. You're still muted. No, sorry, I can't help you either.
Sorry.
Right, you're on.
I think for whatever reason, the video is not working, I think. Is it working now?
Yes.
Oh, thank you. I think reflection is a very beautiful tool, particularly with Georgie. I have to say, I've been involved with her care as well, and with the family, with the other sibling. Using our parents and for our service development, for our reflection process, has been a starting point with this project. And I think the family are very keen to take it forward. And there has been a lot of interest nationally as well, from Birmingham Children's, from Great Ormond Street, which is a really beautiful thing, that this process of taking the parent along the journey of reflection, of learning, has started from Kettering. And I really want to say that, you know, it's very pleased. I'm very pleased to say that's been kind of acknowledged in a few hospitals nationally. And I think it really helps for the families with more than one professional involvement, because it's so confusing and it's so anxious to remember even one single path of the journey. And when multi-professionals are involved, it really helps to kind of coordinate care. Going back to the Red Book that Richard asked about, the Red Book is now digitalized nationally, and hopefully this journal may also be digitalized in our digital journey with KGH.
Okay, thank you very much. Very helpful. And probably finally, Rabia.
Thank you, Chair, and thank you, James and Georgie's family for this absolutely brilliant piece of work. And Lise, you're absolutely right with regards to replicating this work more widely. And I'm absolutely delighted to now share with the board that now we have a patient voice and patient representative, Annie, who joined us as part of patient safety group. And we were only discussing it on last week, that how we can take something similar forward with patients, because this actually is absolutely brilliant, having this co-production, which is very close to my heart personally as well, and having that advisory role from our patients' point of view, not just at the policy and practice, but also at the very beginning of the ideas generating. So just wanted to assure that actually we are not going to stop here. We're definitely going to pinch this idea and try and see where all we can use, so our patients are really genuinely involved in everything we do.
Okay, thank you very much, everybody. Can we repeat what everybody said and thank the family for all their support for this, thank the staff for the work they've done. Can we make sure that the point Dr. Llewellyn raised can come back through quality and safety sometimes in the next 6 months, so we can see what progress has been made on that, and perhaps by them reporting it on up to the board. That would be helpful to keep a track on the wider application of this. Otherwise, thank you very much to everybody who's involved. It's clearly a very good piece of work, and every cloud, as they say. So thank you very much, everybody. Moving on, thank you, James. Moving on, minutes of the previous meeting on the 30th November, are you happy to refer record? Good, thank you. And the action log shows everything complete. Are you happy with that? Yeah. Jolly good. Okay, thank you. So Chair's report, I don't have much to say. Obviously, the big ticket item for the last 2 months has been COVID, and that's fully covered in both Simon and Debbie's reports with all the information about what's happened. The major incident plan declared for Northamptonshire was stood down in the last couple of days. And I think, from my point of view, I think what might be interesting is to try and do some compare and contrast at a regional level about what the impact of declaring a major incident is. It seems to generate an awful lot of noise or heat, but I'm not absolutely certain it generates a lot of light. So perhaps we could see if we can persuade our regional colleagues or even national colleagues to look at the impact of these kinds of decisions that are made and whether they change what actually happens in terms of our discharges and community care and nursing homes and so on. Turning to the ICS, you will know that the progress on that has been delayed. The start date is now delayed till at least the 1st of July. Hopefully it will be the 1st of July. That doesn't delay our elective collaborative at all, which was always due to start on that date anyway. And we expect to continue to make progress on that. And the ICS fairly successfully, 75% successfully, appointed non-exec directors earlier this month. They appointed 3 out of 4. We'll be going out to re-advertise for the 4th post. And I think unfortunately, at least I think we can't say who they are yet, but I think they represent a really good spectrum of experience and wisdom. And I think that will allow the ICS to start working in shadow form during the month of March, probably, where these non-execs will take up appointment either between the 1st and the 31st of March at some point. At least that was the previous best decision we had. Things do keep moving a little bit in this regard. That's all from me. Over to Simon, please.
Thanks, Alan. Just picking up on COVID to start with. Again, I want to just take the opportunity to thank the staff for all that they've done over the last couple of months in particular. We forget in Northamptonshire that although people may be starting to think of a life after this wave of Omicron, during the course of last week, we still had across the 2 hospitals 150 patients plus who were in hospital beds as a consequence of being ill through COVID. So the work continues. I also want to now say I am clear, I think, that we will get through this wave, but I thought this morning I'd just reflect on some of the lessons that I think this last wave of COVID has particularly taught us, because they are lessons that if we failed to learn them prior to next winter, could see us have an experience at least as difficult, if not more difficult, than the ones that we have just been through. So 3 quick lessons from me. The first is really one of capacity, and I'm talking now system level capacity. It's clear that Northamptonshire, we've known this for a number of years, runs very hot as a system. And so when we come under strain across the system, the residual capability of the system to actually do more is very limited. And that has been the case in COVID. I'm not making an argument here necessarily to increase hospital-based capacity. I am making an argument that capacity in general is now pretty clearly running too hot across the system. I'll come back to some of the solutions that I think we need to engage in a little while. But I think it is essential that if we don't get some headroom, and headroom in the traditional sense is simply capacity that at one level is unused, but at another level gives us the headroom to respond to peaks and troughs in demand in a much more robust way than we're able to do at the moment. We don't have a view as a system as to what that deficit in capacity is, but I now think it's critically urgent that we get one, and we get one soon. And I think it's a really important task for the incoming ICS. Second, we've talked in detail and with a great deal of care and concern about workforce. We've talked about all that we've done for workforce throughout the Omicron and previous waves. But what COVID has revealed is that we are simply short of people, short of too many people in 2 critical service areas across health and care. I was talking to one of our directors of social services recently, and he said, look, we contract with 80 care providers for domiciliary care. And on one street, there may be up to 5 different providers working with patients. Now, if you think about it for a second, there's virtually no other setting of care that would operate, or no other setting that I can think of that would operate with such a fragmented model to try and provide what is sometimes the difference between somebody being in hospital and somebody being safely able to go home. We also know now that not only do we have a very fragmented model of contracting for those types of services, we are simply unable to recruit to them. That recruitment problem is not going to change. It's not going to go away. I think we now need to decide, and I'm opening a conversation here, whether we get on the pitch in some of these problems or whether we stay to one side. And if we get on the pitch, how do we get on the pitch? For those of you who are readers of the HSJ, you'll see the first foray into this space by Northumberland Healthcare Trust, which has decided that it needs to get into the dom care business for much the same reasons that I am talking about here. We also know that we are able to recruit nurses. People still want to join the NHS. And I think we're now going to have to look for some of those innovative solutions where we maybe attract the staff. We don't own the bricks and mortar, but we work together with other partners to actually provide services, because carrying on as we are is a route to another winter like the one that we've just faced. So workforce, and I think that opening that discussion as workforce, and the reason why I'm making that point in relation to the ICS is this is not a problem that we can solve on our own. The only way we can solve some of these problems is acting together and in concert across the ICS. And I think there's a real opportunity for us to do so. There's a real opportunity for the people board in the ICS to start to lead some of this work, but I think we're going to have to get on the pitch. And the third level, the third lesson is one of integration. We've made good progress in bringing together a shared agenda across the ICS, but I think we're going to have to quite rapidly accelerate some of the integration around services. So do we stay as solely a provider of acute services? I'm not sure that's a viable or indeed helpful thing for us to do anymore. I think we're going to have to think more laterally in terms of some of these models of care, because it's not just that people want to join the NHS, they want to be part of something that is integrated. And if we think about the way in which people who are working at the front line of particularly some of the care settings, they're in small, bespoke providers, often with not great T's and C's. And I think we need to do something about that too. So 3 lessons from me, but I just want to signal what's keeping me awake at night at the moment is not whether we will get through this wave of COVID. I think we will. In fact, I know we will. It's more what's waiting for us 8 months down the line in winter if we don't take action now. 2 other points on which to close. So the first is vaccination. We are meeting in the trails of some pretty public pronouncements across the news media this morning about a potential change in government policy. To be clear, we have no special knowledge of any change in policy, and so from my perspective, the status quo pertains until we have any further direction to the contrary. So we will continue to discuss the paper that we have on the agenda this morning with the policy that we know and understand at the moment. I'm sure that will be a good discussion. I did want, though, particularly to thank the HR team. The work that has been done to date by our HR and OD team across Kettering and Northampton is little short of heroic in terms of making sure that people have been supported, had respectful and personalised conversations. None of that has been easy, and I just needed to thank them all for that work. Finally, from me for today, as previously reported to board and reported in the press, in July 2020, Northamptonshire Police contacted the Trust to advise that allegations of a historic offence under the False or Misleading Information Act had been made. These allegations related to how the Trust had managed waiting list data and related performance reporting. Since then, and during the pandemic, we've been working with the police to support and assist their review, which has now, I'm pleased to say, concluded, and we have been informed by the police that there will be no further action against the Trust. Thank you very much.
Debbie, I think we'll go straight on. We'll take any questions at the end if there are any. Debbie?
Okay, thank you, Chair. So since I wrote my report for the board, our numbers of inpatients who are COVID positive has increased. So that number today is 89. I won't focus hugely on COVID, as we have got another paper on the agenda a little bit later, which I'm sure Faye will present and go into a little bit more detail at that point. But before I move off COVID, I too would just like to say thank you to our staff, not only for looking after our patients really well, but also for looking after each other in what's been quite a difficult couple of months for KGH and the NHS as a whole. There are two aspects of my report that I'd just like to draw your attention to. So despite the Omicron wave and the fact that we have reduced some of our meetings and time together, we have continued with our weekly Let's Talk events. The events, I think everybody is aware of, and they're really well attended by some of our governors and generally over about 150 of our staff. And together in those events, we are really starting to make a difference. Some of the small changes that we're making are making quite a big difference to some of our staff, which is really good to see. And those changes are simple things such as changes in times that the buses are picking our staff up from the car parks and bringing them into the hospital, for example, making sure that we've got additional lighting on site so that our staff can feel safe when they're walking to their cars out of hours and at weekends when it's dark. And more recently, we've agreed to put some additional volunteers into areas, especially within urgent care, to be able to support relative communications and bridging that gap between the staff, the relatives and the patients who are in. So I'm really pleased with the way that the Let's Talk sessions are going, and we've had some fantastic feedback from our governors. The second area that I just want to focus on, although it does seem to be quite a long time ago now, is Christmas. And that's really just to say a huge thank you to everybody in the community who supported us over Christmas with giving gifts, donations, running marathons. There was all sorts taking place through November and December. And we received a huge amount of gifts, actually, mainly for our children's wards, but a massive thank you to everybody that took place that helped with that. So I think we've covered off the fact that we've stepped down now from the major incident as a county, but our hospital remains really quite busy. And whilst it's busy, we are still planning to restart some routine elective work in the next few weeks, and I'm sure our Chief Operating Officer will talk more about that as we go through the agenda today. We're also continuing to provide some capacity for patients who've waited over 18 months with UHL, and I'm really pleased that we've been able to do this because whilst it may feel uncomfortable for some people, and I've had a lot of conversations in this regard, we are part of a wider NHS, and it's really important that if there are long waiters in other organisations and we are still in a relatively good position with our waiting list, we do continue to try and help other organisations to reduce their waiting times. So the patients that we've started to take from UHL are those with a Northampton or on the borders postcode. So again, really local people. And we've started to book patients in for their outpatient and operations from that area. Just in terms of our people, so this month, in fact today, we are commencing new ways of working. And what does that mean? So in Glebe House, across the 3 different floors, we are introducing some hot desking this week. This is a pilot, and if it is successful, it will be rolled out in the rest of the organisation. We know that space in the organisation is at a premium, so we really think that this will start to help. And Polly has kindly been leading on this project and done a fantastic job. So if you are in Glebe, you will start to see hot desking in place. And also in terms of our people and health and well-being, I just want to finish with the fact that we have committed to refreshing and redecorating 45 of our staff rest areas through the next 3 months, which is great actually, and something that I really focused on when I commenced in post 9 months ago, because some of our staff rest areas do need a little bit of redecoration. So that is definitely one for the staff as we move forward. And I'll stop there, Chair.
Okay, thank you very much. Any questions or comments on anything that's been said at all? No, I'm not seeing anything. No, still nothing. No. Okay. I'm particularly pleased that the false and misleading information issue, which goes right back to 2015, it's 7 years ago now. It's been repeatedly investigated. This must be about the 5th investigation. So hopefully that has now reached the end of the road, and the organisation and all the people who've spent time and effort trying to answer the inquiries can now move on. It's an important step to take because of the very great publicity around the launch of the police investigation in the first place, and indeed other inquiries. Okay, are we done? Yeah. Integrated governance report. Well, my efforts at less is more don't look as if they've quite been achieved in this version of the IGR, but as Andy will no doubt explain, this is definitely a work in progress, and the progress will result in it being much smaller and much more focused. Andy, don't let me down, please, off you go.
Thanks, Alan, and yes, you're absolutely right. I think one of the things to say at this point is we're in this transitional month. This month's the first month of the new set of metrics we agreed last year, and we went through that process to reduce the number of metrics. And so the end point is that board members will only access the IGR through Power BI. And if you've managed to look at it online, you'll see that you're able to filter the metrics by committee or indeed group priority area. But in this transitional month, what you'll see in your board packs is you've also got the full list of metrics as a PDF. And this has been provided in this way just this month to support the transition and acknowledge there's more work to do to make sure all board members can access Power BI, particularly using iPads. So just to know, if you haven't had a go at it, navigating the IGR and the Power BI is through a number of pages that provide access to the metric summaries or indeed the detailed SPC charts. So as Alan said, absolutely, navigating this new version, we knew it would be a basis to iterate from. And there are already a number of improvements that we've identified that we worked on that's in the report, and I'll just highlight a couple of them. So most importantly, filling in the gaps where the metrics are not aligned across the group, ensuring that if we are just using this online, that there's a snapshot taken at that moment of the committee, so we can always go back to see what the metrics were like at that moment in time. We need to do some more work on making it easier to compare the KGH and NGH metrics side by side. As I said, we need to look at testing on iPads and look to see whether there's our NED colleagues can access the full range of features. And there's a number of improvements that have been collected from this round of committee meetings, and I'm sure you won't let me down by giving me some further feedback in this session. So just to finish, in order to prepare for the PDF to disappear, colleagues will have seen some invitations go in your diaries to support you, and that's split into 2 sessions. The first session is just around making sure you've got access to the platform. And then the second one is around being able to use the tool to probe the data and maybe ask some more detailed questions. So what you have here is a first iteration. As Alan said, it's certainly not the finished article, but I hope you'll agree it represents a first good step that we'll continue to build on.
Thanks, Andy. And I think too, it would be helpful if those sessions maybe were videoed and put up if people can't do them, or can just go back and check on them again. I think that would be helpful. Okay, straight on to Debbie. I think we can come back on any points you wish to raise about what Andy said at the end. Debbie, go on.
Thank you, Chair.
Compare this whole session, this whole bit through, please, for me.
I will do my best, thank you. So you can see that the new IGR format's in place. It's been to each of the committees of the board, so we have now got highlight reports. It's arranged now by the 5 group priorities, which you can see, and I won't go through those. But what I will do is invite each of the non-execs in turn to provide some feedback on any highlights and areas of escalation from the committees that they chair. And then I'll take contributions from each of the executive directors alongside that. A huge amount of work going on in the organisation. You can see from the metrics that it's been a really busy couple of months. But if we can perhaps start with quality, and I'll go to Chris first, please.
Thank you, Debbie. So we met on the 25th of January, and the feedback I'd like to give for the board is that we had spent quite a lot of time devoted to infection prevention and control in general, but specifically mandatory vaccination, and I won't say any more about that. We noted that the C. diff number of cases had fallen and was below the upper limit allowed. We had a discussion about the investigation of COVID outbreaks, particularly those of hospital-acquired infections. We reviewed the infection prevention and control BAF, which is a very big document. And I'm pleased to report that we are 92% compliant with all the requirements of that. And the further work will get us as close as possible to 100%. But with our facilities, etc., that may not be possible. Ventilation was discussed, and by ventilation, I don't mean ventilation of individual patients, but the possibility of occasionally opening a hospital window to let in some fresh air. We then went on to discuss the number of superstranded patients and this concept of right to reside in a hospital bed, which is a very interesting phrase, but we noted that the number of superstranded patients was at the time of the meeting, I think 138. We then went on and had a discussion following the paper on mapping the complaints process between the two, across the two organizations, and that we've now got, as it were, the compare and contrast, but we now need the next step to say, what are we going to do into the future so that the two complaint systems provide the same service and metrics. I wanted to congratulate Rabia and her team on the whole of the concept of learning from excellence, because that really seemed to step up and provide really great support to work going on within the organization. And then finally, a paper on virtual consultation safety and the consequences thereof. I'm sorry it's such a long update, but that's where we are. We've also sent in written comments concerning the new format, and I won't go further into those, other than one suggestion, and that is the future events that are coming up to teach us about how to use this. Perhaps we could have one in which everybody is using an iPad, because that's one of the differences we had before was that teachers were on desktops or on laptops, and we were on iPads, and that caused quite a bit of confusion. So thank you.
Thank you, Chris. Rabia, is there anything that you'd like to add?
Thank you, Debbie. Sorry, just took a bit of a while. I will add to learning from excellence, if I may. That is something we are really driving forward from patient safety point of view, staff morale and recognition point of view as well. And slight difference from traditional safety one, where we focus on learning from errors. Our next big focus is learning from excellence and greatness around us. And we are seeing a huge impact on that, Debbie. And one of the elements of learning from excellence is what you've already mentioned in your brief is around Let's Talk, because that is also where we have lots of learning from excellence. So thank you.
Thank you. Fiona, anything for you on quality?
Thank you, Debbie. As Chris highlighted, it was a very detailed and lengthy discussions in regards to the topic areas, and it was very fruitful because of that. And I think one of the strengths that will come from the work that Andy has been talking about in regards to the IGR is the sharing of data across the two organisations, so we can understand and learn from each other in regards to patient care, patient experience and safety agenda, so which we've already started to see through some of this work. So I think there's great progress to be made. Thank you.
Lovely, thank you, Fiona. So if we can now go on to performance, finance and resource, and Damien, please.
Hi, good morning, everyone. Thanks, Debbie. So just to cover the finances quickly, because I don't think there's a huge amount to report on that. We're more or less on plan, and the expectation is that for the full year, we will achieve the forecast break-even position. There was some minor unfavourable variance in the low hundreds of K in the financial month that was reported, but I don't think anything particularly to worry about. We spent quite some time discussing the cardiac MRI business case, which I think we're going to look at in part 2 of the board today. I think we gave some really good challenge feedback to the executive team that came to present. We then had a follow-up meeting in collaboration with the Quality and Safety Committee out of cycle. And I think we got to the right place on that, and we'll discuss that a little bit more in part 2 of the board today. From an operational point of view, I mean, I don't want to just reiterate everything that yourself, Alan, and Simon have already said. There was a lot of discussion about the major incident being declared, about capacity due to Omicron. We also talked about stranded and super stranded, the right to reside point that Chris has already made. So I don't want to reiterate that. I think there's a common theme running through that. The Northamptonshire care system as a whole is struggling with capacity. That has implications for KGH and NGH in terms of being able to discharge patients who are capable of being discharged, because there simply isn't the care packages out there in the wider care community for them to be discharged into. So, you know, we took good assurance that I think the trust is doing as much as it can at this point in time to stay on top of that situation, to work with system partners, and a real focus on discharging patients where they're capable of safely being discharged. That's probably all I wanted to say. Thank you, Debbie.
Thanks, Damien. John, is there anything that you'd like to add, please?
Only a couple of things, Debbie. So as Damien has said, broadly on plan to date, looking for a forecast to break even at year end. There's one probably big issue to pick up between now and year end around the risk to that forecast, and that's simply around annual leave and our accruals. When we set our plan for the second half of the year, I briefed the board that it was going to be a potentially large movement, and we'll need to work through it between now and year end. That still remains the case. I've carried out with the team a review of our annual leave outstanding and the value of that. I'm comfortable that we won't be in a position where we have to drop that accrual. And as a result, kind of release more money into the financial position, making it better. But I've still got some further work to do with colleagues to bottom out the final value and potential impact bottom line, and we'll need to do that over the coming months. So in terms of INE, that annual leave accrual remains the biggest item as it was when we set the plan. Unsurprisingly, our pay bill has gone up a bit. That's expected given the quite significant unavailability of colleagues over the past month or so as a result of the pandemic. But worth flagging that in terms of pounds. And then from a capital point of view, our capital programme remains fully committed. We are working to within kind of hundreds of thousands of pounds in terms of movements on programmes rather than millions, and we'll continue to monitor and manage that between now and year end. I'm not flagging any risk to the capital program as it stands. In terms of the big numbers, because we did spend a little bit of time focusing on it, PFR, we've got an overall program of circa 17.5 million. Our spend to date is 5.8, and then we've got a further amount of money that we've already committed on contracts and other things of 6.2. So the two numbers that the board should kind of log in the back of their head is that we've got a program of 17.5, and we have commitments and or actual spend of 12 against that. We've got some high value spend to make in the coming months, but the procurement processes and decisions to be made to commit that are in train.
Thanks, John. Damien, did you want to come back in?
Yeah, just a quick point on the capital plan. I mean, we did spend some time discussing that, and John's just reminded me, and we took assurance that there is a plan to spend the money and a robust process. But I think it would be just right of me to say, I think it remains a point of anxiety from a committee point of view that all of that money gets spent when we consider the actual spend to date relative to the capital budget. So it's something that we really want to keep a close eye on as we move through the remainder of this fiscal year.
Yeah, thanks, Damien. And John and I are doing quite a lot of work in this regard. So we're meeting with the operational teams each week to make sure that we keep an eye on that. Faye, is there anything that you'd like to add?
Thank you, Debbie. Just briefly, just want to acknowledge the sterling work that Accident and Emergency have been doing throughout January and December, because it's been an incredibly challenging time, and they've managed to maintain some really excellent performance with minimal ambulance handover breaches, which is a real priority. So I just wanted to just acknowledge some of the work, because it has been difficult, particularly with the number of reason to reside or no reason to reside patients that we have, and our discharge profile at times. So thank you.
Thanks, Faye. Let's move on then to people, please. And Janet.
Thanks, Debbie. Clearly at our last meeting in January, fairly recently, a huge amount of time was taken in discussing what was being undertaken to look at the COVID vaccination, and that's on the agenda later. But I would like to say that the HR team ought to be commended for the amount of work that they've been undertaking to try to work this through. So that said, clearly we've heard about staff absences and the issues through John's report. That was discussed at the committee and again on the board assurance framework. So that comes up in a little while. But the other area that I think has been really well done is in terms of the safe staffing report, a joint report between the two organisations. So again, I'd just like to thank Fiona for the work she's put into developing that. That's really important to look at the overall risk in terms of staffing around nursing and some of the other professions as well. And then we're looking forward to seeing the collaboration for the Joint Staff Bank. The plans are being put in place at the moment. And again, that's a benefit to the organisation moving forward. What clearly is an issue for us, but there is a plan in place, is around the completion of mandatory training and appraisals. Appraisals are really critical at the moment in terms of staff morale, etc. So pleased again that we'll be receiving a report of how that will be picked up in March. So thank you.
Thank you, Janet. Mark, is there anything you'd like to add?
No, thank you, Debbie. Janet's pretty much covered everything, and I'm speaking on mandatory vaccinations in a bit, so thank you.
Okay, lovely, thank you. So let's move to CPC, and Alice, please.
Thank you, Debbie. Yeah, in terms of CPC, we are currently looking at the plan of work for next year. So we are, if you like, through the initial phase of getting the initial clinical areas that have worked together to start working together. We've now got our group clinical strategy in place. We've got a group transformation function in place. And I guess then, therefore, CPC is now looking at what we look at over the year, how we structure our work, how we check in with the group strategies and the group vision that we've got in place now. So we are in the process of putting together a plan to look at that for this year and to make sure we're really adding value where we can on those really core group things that we need to get right as we work more together. I think in some ways the scope of CPC could creep to almost everything, because as we do more and more as a group, that could be the case. So I think that the skill is going to be in how we use that time most effectively to really make us go forwards in the best way we possibly can. At the last meeting, we didn't have a January meeting, but at the last meeting, we spent some time looking at the group estates plans and how we might work together more effectively on those, particularly what we might keep in-house and what we might look for more external support on in a follow-up to conversations that have happened at away days for the board at the end of last year. And we also spent some time looking at and understanding the group transformation priorities for 2022 and into the future as well. So those were our two recent focuses for CPC.
Thank you, Alice. Simon, is there anything that you'd like to add?
Just to give advance heads up notice of the fact that the first item that the CPC will be considering on the 14th of February will be one of the major transformation programs around outpatients. That, I think, is a really place where I expect CPC to go, because it starts to cross-cut across what traditionally might be regarded as service redesign into transformation and the digital space. And it will be an opportunity for us to really test how are we doing that? Are we making sure the joins are really joined? And particularly because I expect the future of outpatients to look quite different from the way that we do it at the moment. It will be a really, hopefully, interesting topic for us all to get engaged in. So if that hasn't whetted your appetite, I don't know what will. It's on the 14th of February. So I look forward to seeing you all there.
Valentine's Day special for you all. There you are. Yeah.
Indeed. Thank you. On to Audit Committee and Trevor.
Sorry, just unmuting. Thank you. The Audit Committee, we had a very busy Audit Committee the last meeting, because we had 3 sets of visitors from the operational side to go through 3 elements that are quite crucial. So we got a feedback after 12 months on the clinical effectiveness work. We looked particularly at 2 audits that have been undertaken, one on the maintenance of medical equipment, which was a piece of work that was done both at NGH and KGH. And the third one was around the recruitment and retention piece of work, where Paula came along to respond to the report on that and explain where we were. And I think we've mentioned about the HR department, and I think one of the things that came through in that was the sheer volume, 1,000 staff recruited in the last 12 months, that whilst we have got an audit that has recommendations and requirements, the context of the recruitment and retention audit was that huge amount of work that's been going on there. The SFI is a scheme of delegation we looked at, and that's later on the agenda. And I think the final point was going concern. Normally, this is a massive debate at the Audit Committee. In fact, in the past, it used to be the board. The change in rules, and John might like to say a little bit about this, just briefly. The change in rules means that actually the going concern issues that would have sat at our doorstep, one, because of the way funding has changed and KGH's financial position being that much better, but 2, the rules about going concern have changed that make this actually less of an issue going forward. So we happily agreed that the account should be prepared on a going concern basis.
Thank you, Trevor. John, anything you'd like to add?
Apologies. Yeah, just to give a little bit of colour to that conversation around going concern for those not in the detail of the accounting manuals that prop up my door. So last financial year there was quite a significant change to the scope of going concern. Previously, as Trevor has said, it was very much focused on the future outlook on financial sustainability and whether or not we were basically able to operate from a cash flow or working capital point of view. Were we solvent? Were we sustainable? Last year, the guidance in this area, and I should say the final guidance from an FT accounting manual, the FT arm, the FT arm. I haven't seen the version for this year's set of accounts, but I'm expecting it to be broadly unchanged. It says that you're a going concern essentially if you continue to run all of your services. And we would, as we did last year, make inquiries to our main commissioners to just check that. There is no expectation that services would be taken away from the organisation, or that we were looking to be, or that there are any proposals for the hospital to be taken over or something of that ilk. So given that there isn't anything on the horizon for that matter, that's where the going concern situation lands with. We are comfortable with preparing the accounts on a going concern. We do have further work to do, I think, on behalf of the audit committee and board on that future-looking financial sustainability piece. And the conversation I had at the audit committee was that we would look to do that as part of planning for 22-23.
Thank you. Thanks, John. Richard, is there anything you'd like to add to audit?
No, thank you, not for audit. Thank you, Chair.
Okay, lovely. Thank you. So I have missed digital out. I wanted to just give you a minute to catch your breath, Alice. So digital, over to you, please.
Thank you. Sorry, Debbie, I wasn't sure if you'd forgotten, but that's fine. Yeah, in terms of Digital Hospital Committee, there's an awful lot going on, as ever, in the digital agenda. There's an awful lot to do, both in terms of achievement of the digital strategy that we've set out and the clear plan on that and our objectives, plus also just the level of responding to everything that is going on in the hospital and the wider NHS universe at the moment. So I want to sort of thank the team for the tremendous amount of work that is going on. That said, we're at a phase where we're doing lots. Not everything is going exactly to time, but we are broadly on track, I'd say. There's sort of exceptions to that, and I'm aware it's Northampton, so you may think that's not relevant to us, but I think increasingly as we interlink more, it is. We are still having trouble with our application for funding for the Northampton part of the electronic patient record, just in terms of logistical hoops to leap through. Not that we have any indication that will not be successful, but we are still continuing to have to leap through a lot of hoops for that. And that is, I think, causing a lot of management time focus, I would say. That's why it's relevant to us here at Kettering. We continue to work through that, and Andy may have an update on that since that we may be moving forward better on that. And that obviously delays us from a Kettering point of view to some extent having a fully joined up record with Northampton, which is obviously our ultimate aim, to enable people to work really seamlessly between the two sites. So we continue to discuss that and see how we can move that forwards at the best pace we possibly can. The other things we've talked about were the Northamptonshire shared care record, which has got some more minor delays to it, but is now being worked through, and very shortly should give us at least a step in that direction, albeit only with relatively summarised data, not the full picture we will want to get to with a full EPR in the end. From a team point of view, I think it's important to note that Andy's recently completed the bulk of a restructure so that the digital team now is a real group digital team across the piece. So we have leaders in each of the key functions now that are group people that are delivering across the group, which should tremendously help us in learning lessons from each other, only doing things once, and all those good things that we've already been trying to do. But if you've got two people doing them, there's always a challenge with that. So that's been Andy's focus for the last couple of months. And also we've spent some time looking at the TIF funding projects, which I know are on the agenda for today in more detail, but just to reassure the board that we have looked at them from a digital point of view and looked at the plans for delivery, if you like, from a digital point of view, and given that some oversight, given the challenging timescales we've got on that. Thank you.
Thank you, Alice. Andy, anything that you'd like to add?
Yeah, just to provide a little bit more of an update on the NGH EPR. As Alice said, yeah, it's been quite challenging to jump through the hoops. I'd like to thank John for his help as we've been having discussions at the regional level to see if there's a way that we can go through the process that means that it's more straightforward. And so whilst I'm not able to give a timeline, a revised timeline at this moment in time, I can reassure colleagues that there's lots of work going on to try and look at the various options that we've got to take from this point in order to get to that. The thing that we're trying to get to is a contract award with recipient of that national funding. So it's still very much a live issue, absolutely. And the other thing to note, as Alice said, the senior digital restructure has taken place, and our head of health intelligence, Martin Innes, starts tomorrow. So really pleased about that, and that will add some extra capacity for us in a much needed area.
Thanks, Andy. Looking forward to meeting him as well tomorrow. So the only other committee was the Strategic Development Committee, which didn't meet in December and January. So I think, Chair, in summary, an extremely busy couple of months. Staff absences still remain a concern, but one of the things that we are keeping a check on is making sure that staff are continuing to take their annual leave, which of course is really important. So we've got a daily view of the number of staff we've got on annual leave. Some of our performance indicators are not going in the right direction. Some of that is due to the increase in activity and also staff absence, but I expect as we start to come out of this current wave of COVID, we'll be able to start to turn the dial in the right way on those. And I'll stop there. And is anybody wanting to ask any questions, please?
Okay, thank you very much. Anything at all from the vast list of compare and contrast data? Alice.
Thank you, Alan. It was just a question on the complaints performance, really. And I know I've asked about this before, and it continues to be something we discuss, but it feels like we are really sort of battling uphill to get this under control, and we have been for some time. Can anyone expand on where we are and give me some reassurance that we're really getting to the root cause here? Because at the moment, I feel like this continues to be an issue.
Yeah, of course. Thanks, Alice. Fiona, would you like to come in?
By all means. Thank you, Alice, and a very relevant question. So you'll be aware that our complaints compliance has not been where we want it to be, and certainly in December we saw a further deterioration in our compliance to responding to those complaints that are made to the organisation. And there are two main aspects in regards to the complaints process that we are not achieving. The first one is around the quality of the comments and responses that we are getting back from the divisional teams. So if a complaint is asked and details are required, we're not necessarily getting the detail that we need to respond appropriately to the complaint. The other thing is the timeliness of that response. So if the response comes back and it isn't within the time required, we are then struggling to make an appropriate response to the complainant. Both of these aspects have been reviewed in detail, and we've now set up weekly meetings with our complaints teams. We also have monthly meetings set up with the triumvirate and myself. We've just started that. And as Chris raised, through our Quality and Safety Committee, we undertook a gap analysis to look at the difference between the processes that take place here at Kettering and those at NGH. And we are planning to compare between the two organisations to see what learning we can take place, but also recognise that there are some distinct differences between the two organisations, Alice. And therefore, I know that Debbie is going to be discussing this with Heidi to ensure that we have a consistent approach across the organisations.
Thank you, Fiona.
Thank you, Fiona.
Yeah, Trevor.
Thank you. Going on to back to the work that we're going to be doing or potentially doing regarding Leicester work, and I say Leicester work, I totally understand this is work that some patients might be Northamptonshire, might be Leicestershire. I don't think that's the issue. I just want to be clear that in terms of our targets that we're being held to, this will not fall into those targets. I'm presuming that these fall into the Leicestershire targets rather than our targets. That's one side. And the second one is that hackneyed issue. If we're doing this work, sorry, wear my old finance director hat. I presume there is some pounds coming with this, and is this an appropriate level of funding coming, or is it a token level?
Okay, let's keep going. Rabia and then Chris.
Thank you, Chair. I was just coming back to Alice on complaints and complimenting Fiona's response. Is one of the things Alex, me and Fiona are really focusing on is with the clinical team, trying to focus on picking up the phone and talking to the patient or seeing them face to face as early as possible. And so that piece of work is what we are trying to do in addition to trying to manage the process once the whole thing starts formally.
Thanks. Chris.
Just a comment I was going to make, Alan, is that a more fundamental question is, and Rabi has partly covered it, why are so many complaints coming in writing when, if a patient or relative asks a question at the time, deal with it. And then you don't get into a cycle of a written answer that requires correction, an amendment, further rewriting, and further delay.
Okay, thank you. Would somebody like to answer the money question on Trevor's one about payment for work done for other organisations? John, Debbie?
I can pick that up. It'll probably be helpful to have some of the context around the actual agreement that we've made, and operational colleagues tell me if I've got the detail wrong. You're closer to it than I am. So what we've agreed is that patients will transfer to our waiting list, and they will essentially be slotted into that waiting list in line with our access policy. From a resourcing point of view, we're aside from support from Leicestershire CCG to help us program manage and other types of ancillary support. We are not agreeing a transfer of resource for treating the patients. They are patients that will move from being University Hospital Leicester's patients to being ours. So there isn't a transfer of resource for treating those patients, so to speak.
Can I just add to that, Chair? So in terms of patients coming across onto our waiting list, that will absolutely impact our current patients who are waiting, without doubt. However, there were two aspects to this piece of work. One was to transfer patients to our waiting list, and the other one was for Leicester consultants to come here and operate in one of our theatres. The second part of the agreement is now not going to take place. That means that we will have an empty theatre here, which we are now looking to whether or not we can staff that and continue to reduce our waiting list. That's a piece of work that Faye is undertaking at the moment.
Chris.
Yes, I'd just like to check that the patients who are transferred have been given choice as to remain in Leicester or move.
Yes, they absolutely have. So we accept the patient first, and then the patient is contacted to ask whether or not they are happy to move, at which point we then will book an appointment if they are happy.
Simon.
So good questions on the elective thing, but I think we're going to have to think as a country and as an NHS very differently about how we have operated elective services if we're going to get out of the waiting list hole which we find ourselves in nationally. So the questions that you raised, Trevor, are, if you like, all the reasons why work has never really moved around the NHS before, because people haven't been able to sort the money, they haven't been able to sort the patient transfers. So regional colleagues are really looking for local systems to try and take a leadership role in terms of solving some of those long-term historic difficulties. And we're encountering some of those now, in actual fact. Some of the Leicester surgeons don't want to come and work in Kettering. And so I think we're going to have, so this is a really live debate and one which I'm sure committees will be interested in keeping an eye on. I think it's also, Chris, to your point, going to raise some fairly fundamental questions around patient choice, which again, we're going to have to really confront. Because if people are determined to wait on their waiting list of origin, so to speak, and they've been given an effective choice, I know that, again, colleagues are starting to look at what does that mean for their place in the elective queue. So again, we're going to have to come up with some of these solutions locally and have an opportunity, I would argue, to kind of advocate on behalf of patients, but also be part of the NHS with the N in that part of the conversation to say, what do we think should now start to happen? Because there are many thousands of patients who are waiting over 104 weeks in Leicester. That's the group we're trying to help with at the moment. And I think we should start finally from the point of view that must be the right thing to do to try and intervene in that place. It must be the right thing to do. But the consequences of intervening are going to come up against very fundamentally what we would call the traditional elective operating model for at least the last 15 years. So I don't have any solutions to that other than to say it's great that we're in the debate. We should continue to contribute to it and try and shape the answers in the best interests of patients. Thanks.
Thank you, everybody. Two thoughts, really. The first one is on complaints, where I hear all the words, but they don't give me any sense that anything's going to be much different from the last 2 years when I've heard them about complaints. So I think we need a fundamentally more engaging and committed approach than we've achieved before. I wonder if we can ask for it to be a major item on the quality committee and come back to the board in 2 months in a way that gives the board some sense that this nut might finally be cracked. I say that because the board would take that view itself, but I also recognise that governors have been annoyed, justifiably, for quite a long time about the progress on complaints, and governors hold the board to account, quite rightly too. And I'd be surprised if they weren't going to press us quite hard on this, rightly. So I want something quite significant coming back with meaningful targets, dates, and attitudinal change as soon as possible on that, please. And I think that's what the board is attempting to say today. On the transfer issues, I think Simon's right that we have a responsibility beyond. It's a national health service, and the end matters sometimes. But I do think we can also look at this as a bit of a longer game. I have argued with the regional director that whilst his biggest problem may well be elective waiting times, to reward those places who have the biggest problem would probably also be a bad idea. And I think we can put up a very good argument that this is a vehicle for us to put forward a realistic and urgent case for an elective care hub, which is a major part of the clinical strategy. And I think there is real urgency in that. There is a lot of capital money available, which is a political priority. And I think there is real urgency in getting forward a credible scheme into region or possibly national way for an elective care hub, which also goes some way to Simon's issues around capacity in Northamptonshire and doesn't reward people who have allowed the problem to arise and does reward people who have a remarkably good track record on the waiting list management, in this case, Kettering. So I think we should look at it with a sort of broader spectrum, broader approach to what we're trying to think of here, but equally pretty urgently, because the window for getting a scheme for an elective care hub up and running is by definition politically quite narrow. Okay, anything else at all on any of that? No. Well, by remarkable collective skill, you've got yourself to 90 seconds from the right time for a coffee break. You can have your coffee break, and if you wouldn't mind being back at 11:35, please. Thank you very much. Okay, welcome back. 11:35. We're on COVID system response, and Chief Operating Officer Faye, on you go, please.
Thank you. So I'll take the paper as read, and we'll just give you a kind of current situation of where we're at KGH. So as of today, as Debbie mentioned earlier, we have 89 positive patients and 34 exposed patients. We also have 15 trapped beds in the organisation. And basically, this makes it really difficult in terms of trying to manage our bed base. And due to the transmission rate, we have had some patients that have what we call popped up. So patients, when they come into hospital, are screened, and sometimes they're negative, and sometimes 3 days later, they are positive, which often exposes other patients within the bay and ward, and creates a problem for us in terms of managing our flow through the organisation. So for us, that number has grown significantly since Christmas, and we continue to monitor that really, really closely. That said, as an organisation, we've continued to manage on Opal 3 position, and we've had a relatively low number of ambulance handover breaches. So flow across the organisation, despite those pressures, continues to be managed well. In addition to that, we have a high number of patients who have no reason to reside in our hospitals. And this in main is as a result of patients that are on a pathway and can leave our hospital, but due to the lack of capacity out in the community, we are unable to discharge patients. So as of today, we have 134 patients with no reason to reside, and 104 of those patients are waiting to leave our hospitals to go out on a pathway, whether that's a package of care into their own house or whether that is into a care home. And the reason for that delay is around staff sickness and sometimes outbreaks in care homes, who are equally struggling with staffing issues out there in the community. We also have been impacted by staffing constraints with some of our teams being off with COVID. And at times it has been challenging. And indeed, the first week in January, we peaked at over 500 of our staff being off sick, with over half of those being COVID related. This is now plateaued, and we're sitting at between 320 and 350 members of staff a day. 99% of these are nurses and 4.5% of these are medical staff. To put that into context, that's an average of 1 to 2 nurses per ward. So just thought I'd give you a flavour of what we've been doing and how we've been trying to manage the situation across KGH. So firstly, we opened our winter escalation ward, and that gave us capacity of 29 additional beds. We've also been using our COVID respiratory virtual ward and KGH at home. So Dr. Reddy has led this service, and this has resulted in over 50 patients being managed out in the community that would otherwise have been dealt with in the hospital. We also took a decision early in December to stand down routine elective work. We've carried on with our urgent and our cancer work, but we took the decision to proactively take that work down. And of course, that has resulted in our waiting list growing and some 52-week breaches in January. We've also been working really hard with our PHE colleagues to look at how we can continually review our infection prevention guidance to ensure that we're managing all of our patients across the organisations in a safe way. And it really is a balance of risk at times. We've also ran 2 multi-agency discharge events supported by NHSEI, which have been really, really helpful and enabled us to increase our discharge rate on those 2 particular days. So from a system perspective, obviously we've been part of the system response, and adult social care and NHFT all opened some additional capacity. Whilst we initially saw an increase in our discharges, our complex discharges over the first couple of weeks, it's fair to say that those numbers have significantly reduced, with only 3 patients going out on a pathway on Friday last week. So I think there's definitely some learning that we need to consider when looking at the major incident and how we responded. I think it's fair to say that we did have a benefit right at the beginning, but I think there's more to do within that space. And certainly as a group of chief operating officers across the system, we've agreed that we will have an incident debrief over the next week or so. So KGH has been challenged, but I think it's fair to say not as challenged as some of our colleagues on the periphery. On Friday, NHFT called a critical incident, and our adult social care closed 3 of their specialist care centres. So I think it's fair to say that KGH is far from out of the woods. So we will continue with our tactical control every day, where we continue to keep an oversight of our staffing levels, our reason to reside, no reason to reside patients, and our COVID patients across the organisations. We have a robust super surge in place. We hope we don't need to use that, but we have a plan should we need to use it. We're also looking to how we can work with care of the elderly colleagues and cardiology to increase the virtual ward concept to try and keep as many patients out of the hospital as possible. So I'll pause there, Chair. Thank you.
Thank you. Anything at all? I mean, it is what it is in the sense that it's a historic document. It's a retrospect, but any comments on what has happened and what we need to think about? Yes. Okay. Let's start with Trevor.
Thank you for that very thorough update, Faye. I think the question, I can't see anything in the paper. Have we had to access or needed to have access to the independent sector as part and parcel of what we're doing at the moment? Must apologise for my voice.
Let's just hold that and give other people a chance to come in. We'll go to Debbie and then to Rabia.
Yeah, thanks, Chair. Thanks for that update, Faye. I just wanted to add a couple of things, if I may. So when the major incident was instigated, the thought across the whole system was that we would be able to put additional capacity in place, upwards of 80 beds. It's quite clear that once you get into the detail, things are not always as easy as they seem. So we, as a system, we haven't managed to put the additional capacity in place that we expected or wanted to do. That's outside of the acute hospitals. So I think that's the first thing. The clear and thorough review of the major incident, the effect that it's had, is absolutely key here. We need to understand the overall numbers of additional capacity, how that was staffed, what's actually been stopped, and then what actually happens as we need to start to step that capacity down. So that bit is really key, and I hope that we'll be able to bring an update on that piece of work that the COOs are doing to a future meeting. The other thing that we had was support from the military. And that wasn't necessarily because we went into major incident, but 7 members of the military joined us at Kettering and 7 at Northampton, and provided some support to our staff with just basic things such as giving out teas and helping with the swabbing centre. So a thank you really to the military, and they're with us for a further couple of weeks yet as well. So I think the main thing for me really is, throughout the major incident, we absolutely had some help from partners, but it just perhaps wasn't enough. We have been, the staff on the ground at Kettering have been fantastic in the way that they have rallied round, discharged patients, supported each other, moved wards when they've needed to have, and nobody has complained about that. So I would like to just say thank you to them as well. The final thing for me is we are short-staffed on some of our wards, and you can see that from some of the information, but every single day we have a group of senior nurses who risk assess the staff that we've got, the gaps that we've got, and then move staff around the organisation to make sure that that risk is balanced every single day through the organisation. Fiona may want to add a bit more on that. Thanks, Chair.
Thanks. Rabia.
Thank you, Chair, and thanks, Faye, for that really comprehensive update. Just wanted to add one thing, if I may, Chair. is very immediately we had to set COVID medical delivery units to keep the very high risk patients out in the community who have been tested positive, to prevent them from getting into the hospital or requiring ITU admission. So that was to be able to provide them antivirals and autoantibody infusions as an outpatient. That required quite a lot of setup and medical supervision, but we've been still continuing with that. And that's one of the things it is doing, is keeping those patients at their home, out in the community and away from the acute beds.
Thanks, Rabia. Chris.
Thanks, Alan. Just a couple of things. So Faye's very thorough report, and thank you, Faye, contains some important words. So new words like right to reside, pathway, and complex discharge. I think it might be helpful if a brief definition of those things was sent round so that everybody understands what we're talking about. But a more salient comment I would just say is, as chair of Quality and Safety Committee, the thing that keeps me awake at night is the staffing issue. It is one of the biggest markers of quality and safety for patients and for staff. And I think our staff have done magnificently over the last 2 years, but I really do worry about into the future as staffing becomes more and more challenged.
Thank you. Lisa.
Yeah, just a quick one. I understand the reason for the introduction of the restrictions to the visiting on site, but just wondered whether or not we were tracking certain KPIs and whether or not we had any idea what the metrics would need to be for us to relax those restrictions at any point.
Okay, Simon.
I'll leave others to answer the visiting, so I think Fiona's will come in on that. Just to say again, what do I think this report tells us? I think it tells us that we're at risk of running another go on the hamster wheel throughout the next year, unless we do something very different to what we're doing now. The data is pretty clear on this. When we were sitting here 3 or 4 weeks ago, we were expecting a doubling of Omicron cases into the hospital. By then we were about sort of 50 or 60, so up to about 120. We haven't got there, maybe even more, but we haven't got there. And we haven't got there as a system. We also know that traditional winter demand, for reasons that we don't understand, has been depressed against 2019 levels. So at risk of repeating myself, I think there are the 3 problems that I talked about are the ones that as a system we need to face. And why I am highlighting them is because we cannot, as individual organisations or indeed as a group, solve them. We can make a contribution to solving them, but this is where the ICS has to mean something, because if it is unable to deliver on this sort of aspiration, you might argue, what's it there for? So we could, for example, to Chris's point on staffing, we could continue to recruit nurses and staff some of those care home beds that our partners in social care cannot. But we can only do that if we work together as a system. We could recruit more healthcare assistants and start providing dom care, but only if our partners currently in the CCG think that's a good idea, and so on and so forth. There are ways out of this problem, but what I think I just need to be really clear about is that the road down which we can go on our own and solve those problems is relatively short now. We know this because over the last 3 or 4 years, but even pre-COVID, we have seen a progressive ratcheting up of these issues. So as long as I've been in Northamptonshire, we haven't been able to address these problems. And this time, in my view, surely the best lesson we can learn from COVID is to actually try and start to solve some of these problems. Because I do think the fortunate place that we are in Northamptonshire relatively is that we do have, to end on an optimistic note, an opportunity to solve them. But to be clear, we will not be able to solve them on our own. And that's why the ICS matters and why, frankly, it should matter. It's incredibly important that we make it work for that reason, if no other. Thank you.
Thank you. And finally, a comment on the visiting restrictions, Fiona.
Thank you, Chair, and thank you for the question about visiting. We have indeed suspended our visiting at the moment, and it's a really difficult decision to be made because we know how difficult it is for our patients, families, relatives, and for the staff as well. Because of the high number of patients that we have within the organisation with COVID, we would not be looking to reinstigate visiting, but we will be working across the two organisations to look at how we can implement visiting in a staged approach when it is safe to do so. So although I don't have the measures to hand, this is a structured discussion that we have on a weekly basis across the two organisations. Thank you.
Lisa.
Can I just confirm that in the definition of visitors, we are not including birthing partners, because I understand we were one of the national outliers, which I was really surprised about beginning around excluding birthing partners.
I'm happy to comment on that, Lisa, and you are correct. So the visiting, just to clarify, if there are exceptional circumstances, and often that's associated with those patients that are particularly confused or with learning disability or dementia, but we also adhere to guidance in regards to birthing partners within our maternity suite.
Okay. I suppose there's an obvious question here, actually. Why is this a group problem if the hospitals have different incidents of COVID? Why does this have to be solved in a group way? I'll leave that thought hanging. Moving on, vaccination programs. Mark.
Thank you, Alan. Thank you all. So yes, so vaccination as a condition of deployment is the item that I'm going to discuss for you today. And I think it's fair to say I don't think I've ever presented a board item before where you might all get some news feed that says it's totally different to what I'm about to tell you at the exact same time that I'm presenting the item. But as it stands at the moment, and as Simon said right at the top of the discussion here today, we have been working through vaccination as a condition of deployment within our organisation here at Kettering, which is basically implementing the change in legislation, the change in the Health and Social Care Act of 2008 and updated in 2014, to require that our staff working within a CQC regulated activity role have received 2 vaccinations against COVID-19 before the 1st of April 2022 when this legislation comes into force. So one of the really important things around that we've been discussing a lot with colleagues over the last couple of weeks has been the date of this Thursday, which is the 3rd of February, on the basis that for those colleagues who are currently to date unvaccinated, they would need to have the first dose of a vaccination on or before the 3rd of February in order for them to have the requisite period of time before having the second dose on the 31st of March and therefore being compliant on the 1st of April 2022. We meet and we have met about this over the last 3 weeks on a daily basis. We're in constant conversation with regards to our position and our colleagues' positions with regards to undertaking or receiving the vaccine. We centre that conversation around 5 main items. I won't go through all of them in great detail because I have been to the People Committee and the Quality Committee this week or last week in regards to the process that we're currently undertaking. But our first piece was obviously to understand which colleagues do we have that have not received a vaccination or to whom we do not have their vaccination status, because not everybody received a vaccination within the hospital grounds. So we've been ascertaining that data and information and been working that through with all staff groups and with everybody working in those activities. From a process perspective, we've also in accordance with the guidance that we received on the 14th of January, which is appended to the paper that you have, we've been working through our stepped process of conversations with colleagues in terms of where they are in their vaccination status and therefore what we could help and what help and support we could provide them. There's been quite a huge piece of work in relation to this in terms of, as I said earlier, this legislation is for those that are undertaking a CQC regulated activity. So there is a question for who is in scope, or what roles are in scope and what roles are deemed out of scope. There's been a lot of work that's been undertaken to the extent that we've established scope panels in a similar vein to that of our ping panels when we established that situation with regards to isolation, as to what roles are deemed CQC regulated activity roles or based in clinical areas and which are not, and therefore would be out of scope of this particular legislation. There's been a lot of work that's been undertaken around that in the recent past. We've also been undertaking, obviously, continuous risk assessments of this process. So what would be the impact or the potential risk of implementing this legislation on our services or a particular service, and where that could cause us some, obviously, service disruption and then indeed issues with regards to patients. We have also updated our corporate risk register. So we have an overall risk of implementing VCOD, vaccination of a condition of deployment, which is supported by service level risks, as I've just said now. So we're constantly monitoring that as we work through understanding who has and who has not yet received their vaccination, and who intends to and who doesn't intend to receive their vaccination, because it is a personal choice. From a governance perspective, it's important to share here that should the legislation be implemented in its current format, it would be the CQC that would regulate this under their safe domain within their inspection regime, similar to that they undertake already from a DBS perspective. So do we have DBS checks or Criminal Records Bureau checks, as people would remember them previously being named, for colleagues who need them for that particular role in which they carry out. So they'd be doing a similar type of thing. And throughout this entire process, we've been in constant contact with our system, our regional and our national partners with regards to how we're implementing this and making sure that we're doing it in a consistent way. And I have to say, from across the system, it's been hugely beneficial to work with our colleagues in the social care sector who implemented this legislation similar to this in November. And they've been hugely helpful in sharing documentation and so on and so forth with us, including risk assessment processes and policies and so on and so forth. That's been hugely beneficial. Finally, we've been obviously working with communications. It's a really emotive and sensitive topic, and we have held a number of briefings, both manager briefings, but also live staff briefings that I know a couple of colleagues on the call have attended. We've had over, it was 500, it's now 800 in terms of the colleagues that have attended those sessions over the last couple of weeks. A completely open forum with regards to questions and answers that people could ask. And I have to say the themes of those sessions changed from the outset of them. We had questions very much based on the vaccine, what it contained, the risk in relation to the vaccine in terms of certain conditions such as fertility and so on and so forth. And it moved last week more into process-based questions in terms of a risk assessment process, scope, documentation, and so on and so forth. But we continue to have an open dialogue internally, because we understand, as I said, this is a really emotive topic. We've spoken at length today about the situation that our staff have faced in the last 2 months and indeed 2 years. And this is an additional pressure in terms of that particular position for them. So we've been working very closely and very sensitively with colleagues. We've also been working on some external communications, but I'll bring Teresa in here perhaps just to work through what we've done in terms of external communications, and also a really helpful suggestion from one of our governors at the Quality Committee last week. Teresa?
Good morning. So from an external communications point of view, we have been following the regional approach and using some lines that have developed from national guidance. We have had some media queries relating to this, particularly from local media, and we've handled those in accordance with what we've been asked to do via the regional team. We're also watching what we do on our internal Facebook pages, because they have become a bit of an area where people were getting quite heated in discussion, and it was taking away from the message we were trying to deliver. So we've amended our stance there and are now just continuing with internal communications via the channels that we can manage. Any questions, I'm happy to take those.
Thank you, Teresa. So overall, that's the position in terms of vaccination as a condition of deployment as it stands currently, as I say, unless anybody's got any more updated information in the last 5 minutes that I've been speaking. So thank you, and I'm happy to take any questions.
Okay, you've got more on this in the afternoon session, but anything on that you want to raise at the moment? Nope. Okay, thanks very much. We'll come back to it in at 1 o'clock. Green Plan, Polly.
Thank you, Chair. Yeah, so you've all got a copy of the Green Plan that's been worked up. So you will hopefully, all board members will know that back in 2020, NHS Net Zero was released, and we, as an NHS, signed up to some quite tough carbon reduction targets that are set out in the paper. And the first step on that journey was in the 21-22, so this year's planning guidance, which is that every trust, every organisation, every ICS needs to have a green plan signed off by board and have a board level member responsible for it by April. So at Kettering, we didn't have one. So this is the first time that we've started to pull together a green plan. That's not to say that lots of staff and lots of departments haven't been doing their bit and been doing lots of work. And hopefully that's come out quite clearly in the document about all the good work that's already been happening. But nevertheless, it wasn't pulled together into an overarching document. So that's what this document is, and it's a first step, I would say, really in understanding the things that have been going on and where Kettering is, and then some of the things that we want to really start to make some progress on over the next couple of years. But of course, this is much more than just ticking a box of achieving the planning guidance. You know, we're all very much more aware in recent years of the impact of human activity on the natural environment. And in the NHS, I think 4%, we account for 4% of the entire UK carbon emissions. So it's a huge amount. And it covers, you know, our buildings and the way we run our buildings and our energy, our waste, single-use plastics, our supply chains, and the energy consumed in providing us with all the things that we need to make the hospital run. And of course, even things such as travelling for staff and for patients and the medicines that we prescribe. So there's lots of things we can do to really start to improve the way we use every aspect of our daily job and the impact that that will have. And of course, that's really for the benefit of the health of our local population. And our local population is our patients and it is our staff. So if we can improve the things that we're doing, we will have a healthier local environment for them, and our people will keep well longer. And that's obviously the key thing that we want to be doing. But I guess finally, this is the start of a journey, I would say. So we're going to be setting up alongside, Peter's going to support with the governors, and we're also going to have some non-executive representation, a sustainability development committee. So that will start to meet. We've already got quite a few engaged staff that are out there. We've been out at our different staff briefings over the last months and asked for volunteers and people who are passionate about this kind of thing to come forward, and people have, and that's really good. So we really want to start to develop and broaden that kind of bottom-up movement of change, really. And the other thing really is working across the systems. So we have an ICS Strategic Estates Board, or System Strategic Estates Board. We have been discussing this item there for quite some time, and we've got broad support both from our unitaries, Ambulance Trust, the university, and all the NHS organisations to really make 2022 a year where we come together. Yes, we write a document that's the ICS Green Plan, but much more than that, we start to look at what are the real opportunities that by coming together we can make bigger improvements. A lot of that will be about space consolidation. It will be about joint approaches to procurement, to waste, working together and in our local communities to improve walking, cycle routes, transport. So there's a huge amount that we could do, and we'll be setting up a system-wide workshop in the next few months that the university is going to be supporting to help us to draw out some of those key themes. So yes, Chair, this is a first step and from Kettering Hospital as to our green plan and the work that we'll be doing over the next year.
Okay, thank you, Polly. You're right. It is the first step, isn't it? It's a plan for a plan, really. And we're a little bit behind the curve in the paperwork, at least, of this, but there have been some quite good conversations, and it plays very much to the strengths and interests of our governors and our staff governors about contributing to this. So look forward to seeing the group reporting up through the SDC. Richard.
Thank you, Chair, and thank you, Polly. This is something that our staff are really, really, really keen on. We heard it just last week at the staff listening event. You know, someone asked the question, have we got a green plan? So we're able to say yes, and it's coming to board on Monday, which is great. I was also asked on Friday last week what the trust is doing about recycling, because all our waste goes to landfill. And I was able to tell them, because I know and have known for a couple of years, that we have commingled waste. And if you put it in the bin, everything that's recyclable does get recycled. So there's a plea from me here about a communications plan for our staff, for the public, and for the governors, because we're already doing an awful lot. We signed a a plastic pledge a few years ago in the boardroom when we were having physical meetings. We're doing a huge amount, but people don't necessarily know about it. So a plea to keep spreading the word. Thank you very much.
Yeah, point well made, Richard. Chris.
Thank you, Alan. 2 points. Polly, first of all, thank you for what I think is a very good paper, a very interesting read. I was surprised it didn't mention or focus more on one-stop clinics or one-stop events for patients so that they don't come to a clinic, then come back for an investigation, reduce travel. But I have to say, it was the final page which really did make me smile. And that was, we're thinking of reusable theatre gowns and caps for someone who started their professional life, first 20 years, reusing all of those. We're going back.
Thank you, Chris.
It wouldn't be a bad thing if climate went back as well then. Okay, any other comments at all? You're just showing your age, Chris, although I do remember those things as well. Anything else at all? Anybody on that? No, good stuff, Polly. I mean, you're right, it is of interest. It's of interest to the board, a lot of interest to the board, a lot of interest to governors, a lot of interest to staff. And I think there's a lot to be done. So we've been talking about it for quite a bit. Richard's right. There's a fair bit of communications to be done here to staff and to our patients about what we're doing. But there's also a lot to be done, which you've got in here as things to be done going forward. So look forward to seeing the next iteration of the plan coming up through the committee structure. Thank you. Richard, Board Assurance Frameworks, item 9.
Thank you. So this is the Q3 review of the Board Assurance Framework. It's been around all the executive leads for the third time this financial year. This includes both the KGH specific Board Assurance Framework and the group BAF risks. You can see a summary of the changes, and I'll just point out and highlight a couple of things. For the Kettering specific BAF, we can see an overall increase in the risk profile, i.e. the risk scores, against a couple of risks which triangulate very neatly with the conversations we've been having earlier today, highlighting pressure in the system, out of hospital capacity, and the pressure that we face within the hospital around COVID. And then secondly, just to comment that the audit committee, so thanks to Trevor, Lisa and Alice, did a deep dive recently of all of the risks on the Kettering BAF, have provided a lot of commentary and feedback. This is the annual review that the audit committee do. And we'll be feeding those comments back to the executive leads and taking the recommendations through the committee cycle as we go forward. And I will leave it there for questions. Thank you.
Okay. As he says, any questions? It's been through the entire process, but that doesn't mean there can't be questions. So, any questions at all? Trevor.
Not so much a question, but it's just referencing back to what Richard said about our deep dive. Some of this was not just about the specifics in individual BAF items, but also how things are presented so that the BAF becomes a usable tool. And we did feel that in some way, some of the redesign work that was done actually had led to confusion. And so what we're hoping is in the near future that we'll be sort of looking at trying to make it a more usable document. We got to a situation that we've sort of slightly over-engineered bits of it. Certainly when we were looking at a number of the BAF items, they were group items, whereas we were looking at KGH, we were saying, why are we looking at a KGH BAF item on this? Because actually now, in reality, these are group, and in fact, some of them are system. So I think there is certainly a lot more work to be done on this. But thank you, Richard, for your and your team's help on that.
Any other comments on that? I mean, it's meant to be a pretty pivotal document in sort of focusing us on what the problems are and what we need to do. So I take your comments, Trevor, that if it's not turning it in, if it's not managing to hold its place as the the document that should drive some of our decisions. We've got a bit more work to be done on it. I presume that's in hand, Richard.
It is, yes, Alan. So we had some conversations in the audit committee deep dive around the revised format that we agreed between ourselves and Northampton. And I have since met with David, the audit committee chair at Northampton, agreed with him that we'll introduce an audit committee deep dive process at Northampton, which is not something they've done. This is our 3rd annual review here. So I'm very hopeful that we reach a consensus on that and we can take it forward together, along with other work that the audit committees can do around supporting alignment of corporate risk strategies and the corporate risk registers, etc. So it's really helpful feedback from the audit committee.
I think that's good. I recommend you also engage with the soon-to-be chair of the audit committee at Northampton, Elena Octava, who brings what I think we all saw in the Northampton board, at least those of us were there, a refreshingly different view about BAFs and risk. So she's going to take over sometime this year, and I think it would be wise to engage her in what is clearly a very necessary review of the Northampton BAF, which has been allowed to drift very badly. So look forward to seeing that going forward. Thank you very much. Scheme of delegation, still the Richard Apps show.
Okay, thank you. This is Richard and John. So I'll invite John to come in with some detail around the SFIs in a second. But just to summarise, taking the paper as read, we've made some changes in this annual review. So thanks very much to Richard May and Fru Coles in finance who have led this work. Changes to reflect the group arrangements, differentiating now between the Chief Finance Officer and Hospital Directors of Finance, which we weren't able to do previously due to the creation of the group CFO role. We have made some changes to how we approve temporary staffing, and we have made some changes to the financial delegations to align ourselves with Northampton. We have also, now that the audit committee has received the annual accounts of the merged Kettering Hospital charity, which is now merged with Northamptonshire Charities Together, we have removed from the scheme of delegation references to Kettering Hospital charity. And I'll pass over to John for any other details he wishes to give.
Thanks, Richard. So just to kind of follow up on some of the detail on that, the expectation clearly being that we are able to align decision making and in particular the levels of authority. So colleagues that have the document in front of them or have read it will see that there are specific references to values changing. If I just run through them very, very quickly, essentially divisions with approval limits up to 100k within budget or where a business case for capital has been approved. Hospital management team with approval limit up to £250,000. That was previously investment management committee or IMC. Neither Debbie or I sit at that forum, so it is deemed to be essential that we that we change authority certainly to a forum that Debbie leads, and then the kind of the gap then between the hospital management team and board committee PFR would be picked up in conjunction with myself and either Simon or Debbie as group or hospital chief executive. That essentially allows us to have a set of conversations both at a hospital level and then across the group, where those investments are deemed to be essential and most appropriate. PFR approval limit then gets reduced from 5 million to 3 million in line with the board approval limit at NGH, and therefore the cases that will come to the board of directors would be anything over £3 million. Now I pause there because as part of the conversations that we're going to have in part 2 around hospital and group governance, we've got a body of work to do around kind of committees, roles, responsibilities, etc. as we move forward, and I would expect that there would be a review of this in line with that time frame. But at the moment, but what it does at this point in time, as Richard has said, is it updates for the key people and key roles that are now in existence. It allows us to have a consistent set of approvals at specific financial limits, and it allows us, certainly at a hospital level, to move that decision making to a forum where the most senior decision makers are based.
Okay, thank you very much. So this is recommendation from the audit committee to change the scheme of delegation and the SFIs. Are you all happy with the suggestion? And it's an interim one as we sort out the governance arrangements. Yeah. Yeah, that's good. Thank you very much. Fit and proper person declarations. This falls to me. You'll be delighted to know that you're all still fit and proper people. And you all filled in the forms, and even down to a pleasing reduction in road traffic offences. So we're very pleased about what's all been happening, and I'd be grateful if you'd accept my recommendation that you all members continue to meet the fit and proper person requirements. Good. Thank you very much indeed. Yeah, we don't have any questions from the public, Richard, do we? No, thank you very much. Any other business? Anything anybody wants to raise? No. Okay, can I ask that you pass the resolution to exclude representatives of the press and public for the remainder of the meeting having regard to confidential nature of business? Nods will suffice. Thank you very much. And I shall see you on a different link at 1 o'clock for the, it is 1 o'clock, isn't it, somebody? Yes, 1 o'clock for the part 2 meeting. Thank you very much for all of you who've been here this morning and those listening. Thank you. See you at 1 o'clock.